Our speaker today is Dr. Jae Kennedy, and he is a professor of community and behavioral health in the Elson S. Floyd College of Medicine at Washington State University in Spokane, Washington. He is the president-elect of the Alliance for NIDILRR, so National Institute of Disability Independent Living and Rehabilitation Research Grantees. He received his PhD in Health Services and Policy Analysis from UC Berkeley in 1996. He has a psychiatric disability and has been a part of the international independent living movement since the late 1980s. The title of his talk today is Disability Perspectives of the Adverse Effects of Medical Ableism. I will say I've had a preview of the results, and they're really important work and really foundational, and very excited that Jay and his co-authors will be sharing this information and the findings today, and really look forward to our conversation. We have everyone is currently muted, but please, if you have questions, put them in the chat, and I will be fielding them at the end with Jay. So, all right, go ahead, Jay.
Well, thanks for the invitation. I guess I want to set expectations a little lower here. Megan is going to review this presentation for the funding agency later this month, and she hit me up at the last minute for this presentation, and it's a little rough. I haven't timed it. I'm going to try and go through it quickly, but if I seem a little frantic or unfamiliar with some of the slides organization, then that's what happens when you get a rough draft, I guess. I'm a white male in my early 60s, and I'm picture behind me is my house, and really the only snowstorm we had this winter. It was freakishly damp and gloomy, but not snowy in Spokane for the first time in my 20 plus years here. So anyway, I'm going to talk today about the disability perspectives on the adverse effects of medical ableism grant that we got from the National Institute on Child Health and Human Development. I'm delighted to see some of my co-investigators have joined this call as well. So Noelle Kurth is the director of the National Survey on Health and Disability, and you may have to pinch hit on me if there's some technical questions about the survey. And also my colleague and friend Jean Hall has joined us as well. She founded the NSHD and was a co-investigator on this project until her retirement last year. So it's good to see some friendly faces in the crowd. And of course, I know Megan too, since she's on our advisory committee. So I'm going to try and share my slides here. And don't see exactly how to do it, and I'm panicking. There we go. Okay. So I need to move you guys over to the side so I can read my slides. There we go. This is the sixth wave of the National Survey on Health and Disability. It was developed 10 years ago under a NIDILRR grant called the Collaborative for Health Reform and Independent Living. Jean Hall and I were co-investigators on that grant. And it was really, I think, the idea to develop this survey was born from the frustration of not having adequate sample sizes or a diverse enough set of people with disabilities to do good survey research with. The NSHD is not a population-based survey, so it's not necessarily nationally representative, but it is a large and diverse sample of adults with disabilities. And the response rate in the sixth wave of the survey, we got over 2,500 adults with disabilities. And for the ableism questions that we included in the survey, 93% of respondents said that they had at least one medical visit in the preceding year and answered at least one of our questions about medical ableism. And this is the flow chart. So we defined three different domains of potential ableism in terms of physical access, information access, supported decision-making, and respect from providers. And we had a preamble for each section kind of laying out a general description of the domain and the rights that patients should theoretically have in these domains. So for example, physical access, we said patients should be able to physically access healthcare facilities like clinics, hospitals, or doctor's offices. Physical access includes things like being able to park, enter the building, move through the hallways, and use exam rooms or equipment. It also means getting the help you need to do those things. We have similar things for information access, supported decision-making, and respect for providers. I'm not going to read all those introductions. But then we had a series of questions within each of those domains. So we asked, in the past 12 months, were you able to physically access the healthcare facilities that you needed? So that was after that preamble that I read to you. The second question was, were you able to get important information about your healthcare in a way that you could understand? The third question was, how often did your healthcare providers support you in making your own treatment decisions? And the fourth question was, how often did your healthcare providers treat you with respect? So the response options were never, I always had problems, rarely, so I usually had problems, sometimes, always, and I don't know. I may have mixed that up. We'll see in a second here. So people who had problems in physical access, never, rarely, or sometimes. So they had at least some access problems. I think I twisted it around. Anyway, so we summed anybody that reported at least some sort of access problem, at least sometimes, or sometimes. God, I'm sorry, we're doing this backwards. I almost want Noel to jump in and pitch it for me here, but let me get it right here. So if you said, I was never able to get physical access, for example, I was rarely able to get physical access, or I was sometimes able to get physical access. Those were all problems, right? Those are all access problems. So we summed all of those. And so in the case of physical access, 560 respondents, or about 23.4% of the sample, said that they had at least some problems with physical access. And that was actually the lowest rate of access or ableism. The other ones, information access was 31%, almost 32% of respondents. 37.2% of respondents reported problems with supported decision-making, and over 40% reported problems with respect from providers. And we're in the middle of kind of the descriptive analyses of who these folks are and how they differ from the people that didn't report problems. I think we can speculate with a great deal of comfort that, for example, people with mobility limitations or sensory limitations were more likely to report problems with physical access, for example. And respect, since that's something that everybody kind of encounters, that had the highest response rate. So that kind of makes sense too. But there are, some questions that are more likely to affect respondents with certain kinds of disabilities. And we're in the process of verifying it now. So I just picked, I wouldn't say at random, but kind of illustrative comments from folks that said that they had physical access problems. So for example, one respondent said, parking is a challenge in New Jersey for everyone, but the supply of wheelchair accessible spots is inadequate in many locations. Another respondent said, people are always surprised when I show up in a power chair. I have to move furniture out of the way. My husband helps me position for pelvic and rectal exams. These are stressful and I have increased pain and anxiety before and after. Another person wrote, to walk into a clinic and check in, then find the waiting area, then go to the exam room, then do all these things in reverse and get myself home often requires more energy than I have in a day. To supposed healthcare professionals and neighbors alike, this looks like laziness, fraud, weakness, or mental illness. And Megan and I have had a talk about that issue. Maybe we can get to it in the discussion at the end of the presentation. But this assumption that people are faking their disability, or it's not really that bad. A lot of folks, and in particular, I think medical professionals, for a variety of reasons we can get into, are very prone to making these kinds of inferences about disabled patients. Here's some information access comments. I'm autistic and I have processing delays. I can't always absorb everything that they're telling me in real time, and I can't always think of questions or other things to add. Another person said, my parents always go with me to the doctor and it's a little annoying. The doctor talks to them most of the time and not me. There are many variations on that theme. Someone observed, there's a problem with medical credentialing and education, not me. Doctors are never required to do communications training, and it shows. And that raises another interesting set of points that we can dig into. So is it an individual provider problem? Is it a system problem? Is it an environmental problem? And is this attributable to the disability status or just the fact that doctors are undertrained in communication in general for patients? Another person said, I'm speech impaired due to deafness and read lips. I do not use sign language. Medical staff don't always give me or tell me the full information, thinking I can't comprehend it. I'm fully capable of comprehending this information. For supported decision-making, a person said, I have a great deal of trouble getting straight talk about the benefits and risks of joint replacement surgery for my severe arthritis, given my co-occurring conditions. We had a number of people with long COVID in the survey, and this was a pretty common type of comment. We need long COVID treatments and for doctors to understand the condition. It's hindering our ability to get adequate care. 3 different endocrinologists turned me back to my primary care physician because they don't want to deal with it and don't understand it. And someone else said the ED treatment system is corrupt. They do not use body autonomy and respect for choices there, and they do not allow you to make your own decisions about your body. This is the respect for provider comments. Doctors are dismissive and treat me with outright contempt sometimes. They will not manage complex cases. Several people mentioned medical gaslighting. Living in chronic pain is very debilitating, and most days we battle with thoughts about why we're here to suffer and not getting the help we need. Doctors often shift the blame for your condition to your habits or lifestyle, even if they're real physical symptoms. They rely too much on blood tests, and even abnormal results are just a fluke. If they can't test it, it must not be real. Someone else said, someone who looks fine but can't walk 1/8 of a mile is often given a hurtful diagnosis as laziness, mental illness, fraud, or deliberate weakness. So it kind of gets you a flavor for the comments. The comment fields are in many ways the most provocative part of this whole project, and I'm not going to get in much to those because we want to do a kind of rigorous qualitative analysis of the themes. But they're very striking, and I'll probably get more comments about them than the data I'm showing. So we had a follow-up question to verify that the access or utilization problems reported were due at least in part to disability status. See if I can be more clear about this. So for everyone who mentioned a problem or issue, we asked, do you think your experience would have been different if you did not have a disability or a chronic health condition? So the theory is that we didn't want to lead the witnesses of their experience into attributing that to their own disability. We wanted to ask them that explicitly. And there are examples we could think of, say somebody goes to a clinic and the parking lot is being, repainted or something like that. So it's not accessible to anybody, regardless of their disability status. So it's saying, would it have been different if you did not have a disability? Well, it's more of a pain, certainly, if you have a disability to park off-site and try and get to the clinic, but it wasn't necessarily attributable to their own disability. So people could respond, yeah, it would have been much better or a little better if I didn't have a disability, or the same, a little worse, much worse, or I don't know. And respondents who said their experience would have been much better or slightly better were deemed to have disability-related problems or issues. So not perfect, but we went around and around on this, and we felt pretty good about the verification. But I've got a whole bunch of comments where people were kind of rejecting the premise in some cases and saying, "Well, the problem wasn't with me; it was with the system. It's too expensive. The insurance coverage is crummy. My HMO doesn't take specialists that I need, or something like that." Um, we can have a talk about whether or not that's ableism. I would say functionally it is. I mean, people with high needs that can't get them met because of their disability or chronic condition are being discriminated against, I believe, in the health system. But anyway, it was an imperfect question. But the good news is that most of the people that said they had these problems said that it was due, at least in part, to their disability. Again, physical access. I'm thinking people with mobility limitations and sensory limitations. This was the most clean-cut example, and 3/4 of respondents said, "Yeah, it would have been better if I didn't have the disability." Information access and supported decision-making, it's complicated and kind of uniformly banned for everybody, getting understandable, accessible health information, and often a very short visit to a provider is a common problem. But over 60% of respondents who reported a problem with information access said that they would have had an easier time if they didn't have a disability. So anyway, I don't want to read through all these slides. And then we have a question about health or healthcare outcomes due to disability. And this was kind of the new piece of this that hasn't been looked at in any of the limited number of surveys that include disability discrimination. So what were the health consequences of this? And we listed 11 possible health or healthcare outcomes. You switched a provider, went to a different healthcare provider or clinic, would be one possible healthcare outcome. Another would be delaying or skipping the care they needed or I needed. Couldn't get the care I needed. So undermet or unmet need, basically. Didn't understand or follow my treatment plan, needed more prescription medication, needed more visits to a healthcare provider, had to go to the emergency room, had to go to the hospital overnight. My mental health got worse, my physical health got worse, or I experienced more symptoms like pain, fatigue, stiffness, and limited range of motion. Again, not exhaustive, but it was a pretty good range of potential outcomes. So the majority of people who said that they had a problem said that there were health consequences to that problem. The highest rate was for people with physical access problems, but it was well above 80% for all of the domains. The most common response was people delayed or skipped the care that they needed because of their unsatisfactory encounter with the health system that they had reported on earlier. So that was most common when there were physical access problems or problems with respect from providers. Worsening symptoms were often associated with these access and utilization issues. So people who were unable to understand their healthcare information, for example, nearly 60% of them said that they had more symptoms because they didn't understand how to treat based on that interaction with the provider. Worsening mental health. There's more of a range here, and I think there's some face validity, I guess, to this respect being associated with mental health. I mean, if you go in and you're not feeling validated or acknowledged by your provider, they're dismissing your concerns, that lack of validation is depressing, making it a depressing situation worse. So I think that's a common issue and widely reported. Physical health, same thing between 40 and 50% basically responded to their physical health worsened because of one of these problems or issues. 12 to 17% of respondents said that they had to go to the emergency room as a consequence of one of these ableism issues or problems, which of course is very costly and just a nightmare to do if you don't have to do it. So, and a sizable number had to stay in the hospital overnight, over 10% of folks with physical access problems. And, the final question I want to just not answer, but let you know about is we finished all of these questions. There was like a clarifying comment field for each of those domains. And that's where I got to push back on things like, are you really sure this was due to your disability or not? But then we have a final open-ended question that says, thinking about your recent healthcare experiences, did you ever have problems because of how you were treated as a person with a disability or a chronic condition? What happened and how did it affect you? And so over half of the people that reported one or more, over 70% of the people who reported medical ableism, due to their disability, took the time to answer this question. And a lot of them wrote lengthy responses. And it's going to be tricky analytically because they raise multiple issues within these stories about what happened to them. But I think this is going to be one of the more provocative areas of research in this project. And right now we're working to recruit medical students at the college I work at to work as coders over the summer on a systematic qualitative analysis of patient-reported issues and problems. And I think they're required to do a research project for their undergraduate medical training, but this will also, I hope, sensitize them to the issues of patients with chronic illness and disability.